Yeah, good evening, everybody. Welcome to this journal club. It's an interesting topic, something that has been controversial for quite some time as to whether one should do surgery or go in for endoscopic treatment of chronic pancreatitis, which, as you all know, is a fairly vexing problem for all surgeons. Uh, Before we actually go into the journal club, I just want to check with our new entrants as to whether they understand what a journal club is or not. Okay, Likith, what do you do in a journal club?
Hello. Good evening, sir.
Good evening.
Yes. We
You heard me?
we choose a particular topic and outcomes of particular surgeries, or we do a
Okay.
study among population
No,
Okay.
what is the purpose of a journal?
Purpose of doing a journal club.
to know the recent updates and outcomes of certain
Okay.
studies.
That's
So
one.
that is one.
Okay. Anything else?
Mm. That
What do you understand by the term critical appraisal of a paper? Are you familiar with that term?
No, sir.
No. Okay. Have you done journal clubs before? How long have you been with us for?
No, sir. Just this is 6 months, sir.
6
5
months.
months.
Is this your first journal club? I thought there was one every month, right?
No, sir. This is second, I think.
Second.
Last 2 months we didn't have any. Last 2-3
Because
months
of
from May.
the monthly hours. Send me a message. I'll send you some links to what a journal club is. Okay?
Yes. Yes, sir.
Okay. Have you read this paper that was sent to all of you? Please answer me. Yes or no? It's a straightforward question.
Yes, sir.
You read the paper.
Yes.
Have you
Yes,
read
sir.
the paper?
Yes, sir. Yes.
You have. How many centers were involved in this study?
30 centers, sir.
Correct. Is it a retrospective or a prospective study?
Prospective study, sir.
Good. Okay. So let's start with the journal club proper. Sameer is going to present it today. Please go ahead, Sameer.
Yes, sir. Good evening, everyone. I'll be presenting a journal club on long-term outcomes of
It's not eating, I will take later. Classes, sir.
Sorry? Yeah. Sanya, please mute your co-host. Please mute people if there is any disturbance. Yeah, please go ahead, Sameer. Yeah.
So I'll be presenting the journal club on long-term outcomes of early surgery versus endoscopy first in chronic pancreatitis. So coming to the details, this was a follow-up of a multi-center randomized clinical trial published in JAMA article. As we know, it is at the highest impact factor of 16.81 of all the publications. And this was an original investigation published on February 2025, volume 160 of JAMA. The main author is Dr. Mara A. Boelmister, who is a professor of surgery at Amsterdam UMC. So this was a two-arm study in which endoscopy first versus surgery first was chosen. And it was a follow-up of the initial study had a follow-up of 18 months, and this has a total mean follow-up of 98 months, almost 8 years, with a focus on quality of life and aim to do subgroup analysis. So the initial trial, to speak about it, the ESCAPE randomized clinical trial investigated whether early surgery offers better outcomes than the conventional endoscopic first approach in patients with painful chronic pancreatitis. It was conducted across 30 Dutch hospitals with 88 patients. The trial compared pancreatic drainage surgery within 6 weeks of randomization and to a stepwise regimen of medical management, then endoscopy and further surgery if needed. Over 18 months, the early surgery resulted in significantly lower integrated pain score, which is the PICI score, which they have, which is a standard validated score. It was 37 versus 49 with a p-value of 0.02, and fewer interventions were noted in the group of early surgery. Median of 1 versus 3, which had a p-value of 0.001, and the end outcomes, which are complications, hospitalization, pancreatic functions, both exocrine and endocrine, and the quality of life were similar between the two groups.
Just
So,
one sec, Sameer, one sec. How many of you read the original paper, please? Can you, this was, the present paper we're discussing is over 90 months follow-up, but the results were initially published at 18 months. How many of you have read the original paper, please? Nitya? Sanya?
Sir, I read the summary of the original paper, sir. Not complete
Yeah.
paper, but from the supplements.
Why would you think summary would not be enough? I submit to you that summary is not enough. You would need to read the whole paper. Why would I say that? If you read the present paper, the methodology which we are going to discuss in detail is referred to the first paper. A lot of
Yes.
it details, when you talk about the methods that they were used, they say please refer to the first paper, which essentially means that you must read the first paper. And if you noticed, I sent all of you in our Sagar group the full text of the first paper. Okay, so that would be a limitation if you have not read the first paper. Second, Aynas, what is ISBK score?
Basically, it is like an assessment score that we use, wherein you are. So there are 4 criterias in that.
Yes.
There are components in that, wherein
Yes.
you are using a visual analog score.
Yes.
Then you are seeing what medication is being given, analgesics, and the dosage that is being given in that.
Yes.
How often the patient is experiencing pain,
Yes.
and whether this pain is not allowing the patient to carry out his activities.
Routine work or not. Good.
Yes.
Good. Go on, Sameer.
yes, sir.
I think, sir,
Yeah.
you should have qualified.
Please feel free to interrupt anytime. This is a
You
free
answered
discussion.
it very well, Ainas, but
Yeah.
what you should say is it is a validated, internationally accepted score that is used for chronic pancreatitis across the board.
Yeah.
So if you
And
speak about SBK score, that means
yeah,
you have actually done a similar kind of study, validated pain score.
and one step beyond the VAS. A lot of us, when we talk about pain, we only talk about the visual analog score. This is definitely one step ahead or better than a VAS score. Yeah. Go on, Sameer.
Yes, sir. So the research question was, does an early surgery approach improve outcome compared to the traditional step-up approach? The early results of the ESCAPE trial, as I mentioned, so the rationale of this study was to measure the long-term outcomes of initial trial, which were questionable, and hence the study was done. As we know, chronic.
Let me correct you there.
Sir.
The results of the first study, 18-month study, were not questionable. It was a pretty good study. But the objection was that the duration of follow-up is not enough. All right?
Yes,
1.5 years is too early. So one of the points that people raised was, what happens at 5 years? What happens at 10 years? Okay, so to answer that, they have done it at a mean of about 90 months or so in this study. Yeah. So the methodology or the results were not questionable. One aspect of it was, but we will come to that when we go further. But the main objection or a limitation of the study was the duration of follow-up. Go ahead.
Yes, sir. I meant that long-term outcomes were questionable.
Correct. Correct.
So, chronic pancreatitis, as we know, it is a progressive inflammatory condition with clinical symptoms of mainly severe pain and damage to exo and endocrine components of pancreas. Incidence of the same in Western population is 7 to 10 per 1 lakh population, whereas in India it is about 114 per 1 lakh population, with Kerala being the highest in incidence. Pain is the predominant symptom and the major problem, rendering about 30% of the patients unfit for work, and there is a significant deterioration of quality of life in these patients. There is also a component of early opioid dependence in chronic pancreatitis, which I will be mentioning in this thing. So, pain pathology of the pancreas is divided into four etiology. First is the ductal and parenchymal mechanism, in which, because of ductal hypertension, the obstruction of main pancreatic duct by either stones, strictures, or inflammation, it will cause increased intraductal pressure and causing pain. Further, there will be parenchymal hypertension, inflammation, edema, and fibrosis, which will increase the interstitial pressure, compressing the intrapancreatic nerves. Finally, there will be ischemia, fibrosis, and microvascular changes, which contribute to the decreased pancreatic blood flow, which cause the ischemic pain. The second is the neuropathic changes, which are due to the perineural inflammation, fibrosis, nerve hypertrophy, and upregulation of pain receptors like substance P, CGRP, neutrophils, and there will be receptor sensitization, and neuropathic remodeling will happen, which causes hyper excitability of nerves. Third will be the central sensitization, which is actually shown in functional imaging in patients with chronic pancreatitis. They show a altered central pain processing, leading to hyperalgesia and allodynia, which is pain from non-painful stimuli and pain from like exaggerated pain from the normal noxious stimuli. Finally, they also have psychological factors, which will be anxiety, depression, because of the worsening pain perception. Opioids will also cause opioid-induced hyperalgesia. There are also genetic and epigenetic factors which cause heightened pain response in these patients.
Sameer,
Yes, sir.
I think the first statement, you go back to your previous slide. The first statement you should make is that pain, though, is the most predominant symptom of chronic pancreatitis, the mechanism of pain is very poorly understood. Even today, all these are hypotheses, but none of them have been actually proved. I think you very elaborately, told all of these things, but still, even if you address each of these specific issues with particular painkiller, celiac nerve block, and by reducing the ductal pressure by surgery or whatever, still a significant proportion of these patients will continue to have pain. So the
Yes,
mechanism of pain is poorly understood. That is the first thing we have to acknowledge.
yes.
Okay.
So the traditional step-up approach which we follow is medical management, further endoscopy, lithotripsy, and then finally surgery. The early opioid, then coming to the study design, this was a follow-up of a randomized clinical trial comparing the early surgery versus early endoscopy, conducted in 30 Dutch hospitals with the intention to treat analysis. So this is the trial profile in which 88 patients with chronic pancreatitis in the initial ESCAPE trial were selected. 44 in each were randomized. One in each were excluded because they did not consent. Then 12 lost to follow-up, in which 11 died in early surgery group and 12 in the endoscopy first group. Finally, 31 have returned questionnaire at the end of follow-up and 30 in the endoscopy group. So these are the hospital institutes of the Dutch the hospitals. All the procedures were done in specialized high volume centers. Surgeons particularly have a experience of more than 50 pancreatic resections or drainage procedures before the trial. And on the other hand, gastroenterologists and endoscopic interventions performed by expert therapeutic endoscopists who have an experience of at least 100, more than 100 ERCPs per year, including pancreatic stenting and stone clearance as their in their experience. So the inclusion criteria, uh, uh, adults with painful chronic pancreatitis, dilated main pancreatic duct on imaging, recent start of opioid therapy, that will be 6 months for weak opioids, 2 months for less than 2 months for strong opioids, and the patients who are eligible for both endoscopic and surgical drainage procedures, and who have provided informed consent for the same. They have excluded the previous pancreatic surgeries, endoscopic, if there were any pancreatic drainage, pancreatic cancer or suspicion of malignancy, any contraindication to surgery on anesthesia, significant comorbidity, including this study participation, pregnancy, and ongoing alcohol abuse without any willingness to stop. So the early surgery group, these were the surgeries which were underwent in these patients: Frey's surgery, Partington Rochelle, Whipple's, Beggar procedure, and distal pancreatectomy. For the endoscopy group, ERCP with pancreatic stent placement, endoscopic sphincterotomy, stone extraction either by basket or lithotripsy, stricture dilatation, and extracorporeal shockwave lithotripsy were performed. So the expected outcomes were ITSBK, the pain score as the primary outcome, complete relief, VAS pain score, SF36 QOL for the quality of life of patients, any re-interventions, mortality, and patient review. Patient review was mainly by satisfaction.
Okay, we have answered this. Yeah, go on. Sure. Yeah.
So ISBK pain score is a compact pain score with components of frequency of pain attacks, visual analog scale, and analgesic medication, and inability to walk. So this has the questionnaire wherein patients will answer whether the pain attacks like how are the pain attacks, whether it is constant pain, severe constant pain with reduced pain in between, how is the average of the severity of pain, how is the worst severity of pain and least severity of pain. Also they answer the current pain medications and the frequency, and what brings pain to the patients. Also, the apart from the pancreatic pain, if they have any other pain, and finally, how is the pain? Like what kind of pain? Aching pain, heavy pain, or the.
As you can
So
see, this ISBEC score is a very comprehensive, detailed assessment of the pain, which one expects. It's actually validated, as Ravi said. One expects it to give you much more reliable information about chronic pancreatitis pain than any other assessment of pain. Go on.
as a for statistical analysis, both post-hoc per protocol analysis and intention to treat were done. For normally distributed data, independent t-tests were used. Non-normally distributed data, Mann-Whitney U-test were used. Chi-square was used for categorical values, and for small categorical values, Fizer's exact test was used.
Yeah, here, in fact, Sameer had wondered if this post hoc analysis was correct or not. This post hoc per protocol is completely acceptable, right? They have, as you can see, they had done some subgroup analysis, but that subgroup was not invented or formed after the test. It was specified in the original protocol itself. And so, under those circumstances, post hoc analysis is acceptable. Okay, go on.
Sanya or Nitya or you, anybody, what is the essential difference between ITT and per protocol analysis?
Sir, in the intention to treat analysis, initially, whichever group the patient were assigned, regardless of whatever happens during the course of study, as per the initially assigned group, they will be analyzed, sir.
Yeah,
Uh, and in the per protocol analysis, basically only the patient who have completely adhered to the study protocol and who have completed the treatment as per the protocol, they will regarding to that protocol they will be analyzed, sir. Like
correct.
Correct.
Essentially, what you said is right. So, what is the difference? For example, which is better?
intention to treat analysis is better, sir,
Why?
because um, basically it will I mean first the whatever hypothesis we had, it will give us the real scenario, like what is the I mean, I don't know how to put it forward. Basically it's like it gives the real world scenario, like what was the hypothesis and how the uh, uh,
You're right, but we can. Anyone else can improve on that? I think Nitya said it correctly.
Sir, it will reduce bias, sir, because of randomization.
I think that is
Election.
That
that
is
is the
the
word.
word. That is the operative word. Yeah. Yeah.
So,
And
per protocol analysis will give you the efficacy of the particular treatment. But if somebody has opted out, then basically your study will be skewed, and the bias, there is a definite predilection for bias. So that is avoided by the intention to treat analysis. So that is the essential difference. So if there are not many dropouts or if there is not much of change, then per protocol analysis will almost be similar to ITT.
Right. Go on.
yes,
All right.
critique.
Now it's open to critique about this methodology. That's why I said if you have not read the original paper, then there may be some issues, but to the extent possible, please critique up to this point. Nikita.
Sir, the main common point, sir, it's a recent study, I mean, like a recent analysis of a long-term study and randomized control trial. Those would be the pros, sir, and it's a reputed journal.
Yeah.
My cons would be, sir, as you said, in comparison to the original study, the main thing which bothered me was that in the original study, when they were doing the follow up, every month they took the questionnaire, every month they had the pain scores. But here it is at the end of the whole follow up, sir, like the endpoint, complete endpoint, they took one score.
Yeah, but then they did
The
ask
trend
about
is,
the frequency and how
yes,
much
sir.
it troubled them and all that. So that they don't have to do it every month.
Yes, sir. Yeah.
As long as they got a global picture about how the course was over the next 5, 6, 7 years, then it's acceptable. Yeah. So it's not a
Yeah.
big con, it's not a big
They've also said
negative.
that apart from the point analysis, they have gone back to 60 days
Yeah.
before to see if there
Intervention
was any
phase, sir.
change. Yeah. So I think
Yes.
it's fairly good.
Yeah.
Okay, sir. And
Okay. Anybody to add, Praveen?
Sir, but that will make us recall bias, no, sir.
Yeah, every questionnaire will have a degree of recall bias. I agree with that, but it's not, Nikita's point was that it was not frequent enough. But yes, I agree that every questionnaire will have a recall bias. I agree. Yeah. Anything else?
very good follow up. That is the hallmark of this study, sir.
Yes.
But the thing is, smaller sample size of that could have been even more bigger.
Very good. They started
sample.
with 44 and ended with 30 in each group. Yeah. Okay.
Pro would be a multi-centric study with good experienced
Yeah.
like doctors in both.
Experienced, I agree, Sanya, but multi-center trial, how do you, even in good place, how do you ensure the quality of data collection? Different people, so many people involved. when
Yes, sir,
they,
but
yeah,
they do have a like for pain score and all. They have like a
yeah,
validated
but
this thing, sir.
how diligent is data collection?
That we cannot
30
just
centers
yes.
and 60 people collecting data versus 1 or 2 people collecting data. So actually multi-center, the two with 30 centers, I think is a negative point.
Okay, sir.
Okay, even though you trust them, but it's a negative point.
Sir,
But
I have
why
seen
did go on?
all students seem to think that a multi-center trial is better than a single center study.
Yeah,
It's
it is
not
not.
the case. It's not the case.
They are forced to do multi-center because they cannot get enough numbers in 1 or 2 centers. That's why they end up with doing it in a lot of centers. Okay, but I must admit that in a systemized healthcare, like in the Netherlands or the NHS or something, people who participate even from 20, 30 hospitals are generally diligent. But by and large, note that multi-center trials, there can be a question mark on the diligence or the accuracy of data collection. That is something that I have in mind. Okay. Anything else? Okay, Sameer. You want to add anything, Ravi?
No, sir. I think
Yeah. Niranjan?
And sir,
Sir,
though we are calling it prospective, whatever the data collected for the second interventions, the post study interventions are through the records, right, sir?
Yeah, but then it's completely the methodology is watertight, right? It's
Yes,
only
sir.
so that won't interfere. If there are some other if there were some interventions, it was collected. So I don't think it suffers from the disadvantages of a retrospective study, because the original cohort is clearly defined, very well defined actually, and it is randomized. So that won't be a disadvantage. Go on, Samir.
sir, my only thing was about the first study, whether because the inclusion criteria was ductal dilatation. I didn't see whether there was any categorization of whether it was just a ductal disease or a combination of parenchymal disease or isolated parenchymal disease.
Yeah,
So whether
that's
that will
a
the
valid
final
point.
outcome.
But the other thing about it was that their definition of a dilatation was 5 mm.
Correct.
Yeah, so
So
they were offering surgery for a fairly.
that is what my question was, because
Yeah.
the pain factors will vary depending on what kind of disease it is. Because if we intervene for a purely like mainly parenchymal disease with a ductal dilatation of 5 mm with one single stone, the pain may not go away.
Yeah.
Or the vice versa.
I agree that they have not done much about the parenchymal calcification, but they did look into the ductal clearance, which they have defined. Whether the group had complete ductal clearance or not is something that they did look into. Parenchymal, what percentage at parenchymal calcification? Something I don't think they've given us data about. Yeah. Go on, Samir.
Yes. So, closer count methodology. It is a randomized clinical trial with long-term follow-up. Separate consents were taken for this long-term follow, wherein only 2 of 88 did not consent. The others were already mentioned. Sir, multi-centric trial.
Yeah, I don't know how you ended up putting it here.
Sir,
I might have missed it if I put it earlier, but as I said, I always consider that if there are many centers, it is a downside rather than a pro.
So the generalizability will be more, no, sir, because it is.
No. As I said, you do a multi-center because you don't have enough centers, enough patients in one center. But the control on data collection, control on procedures, control on all aspects of a trial will be better if there is one center or few centers or a few centers. 30 is a very large number. So that is, I would put it on the other side. Yeah. Go on. Small sample size we have mentioned. Yeah.
The 3 interventions were not standardized. Like it was
Yeah.
to the.
See, this is the important thing. They are, of course, analyzed the pain or this big score and all that at a later stage. But the reintervention was not as tightly defined as in the original randomization. So when something happened, any person, the person in charge there at his convenience or his
Discretion.
expertise and discretion did what he wanted, which means that in the small percentage who had re-interventions, that control is gone. So that's one of the negatives. Yeah.
And also was the same thing applied in the original study, sir, for procedure? He listed out so many procedures. Was it
Yeah.
standardized? Like
Yeah,
for
yeah.
this particular kind of disease, this was done.
Yeah, that is acceptable. Now, what I meant was, when and how did they decide to
Correct.
re-intervene was what was not controlled. But in the initial stage, it was clearly defined. That's what I meant. What they did depend on the case, and one presumes that they had clear cut. If you see the original paper, they said where they did a pancreatic jejunostomy, where they did a phrase, and things like that. That is fairly defined in the first intervention. The other important point that I felt was, they talked about opioids, low and high level of low opioids. What was the criteria for starting it? That is something that they have not defined. But one presumes there will be a reasonable uniformity in that, depending on the patient's complaints. Yeah. Go on, Sameer.
Yes. And whether open or laparoscopic surgery were not mentioned, sir.
Yeah.
Sir, there was actually an expert group mentioned in the initial escape trial, sir, which had the pancreatic surgeons, gastroenterologist, radiologist, and pain specialist.
Yeah.
So whatever decision was taken was then referred to them and then taken up, sir.
I know, but what were the numbers in terms of laparoscopic and open surgery? What was the laparoscopic experience? Though that part of it, even I've read the original one, I didn't find, unless I missed it, I didn't find that information. Did you?
No, sir, it was more of open, sir. I went
It's
to
all
those.
right, but how many? Was the numbers defined?
No, sir, numbers were not defined.
That is the point. Yeah. Yeah. And normally in any study, we have a definition for the follow. They should all come at a given time and all that, which in the second arm was not available. So that, as it was also raised earlier, I think Niranjan mentioned it, or somebody mentioned it, that or Nikita. Basically one point they did that, but there was no clear definition of follow. But please note that to get a kind of follow-up, at 6 months or 1 year, prospectively for years on end, 5, 6, 7, 8 years, more than 90 months means 8 years. So it's very difficult to do that. And so I think if one looks at it practically, that is not a big con, it's not a big negative aspect. Okay, anything else to add? Okay, carry on. Submit.
So coming to the results, the pain scores which were in the surgery first group had a significantly lower pain scores over the endoscopy first group, and this was across all the time points, yielding that surgery was more effective in long-term pain control. And also the opioid use was low in patients who have taken up surgery first. Complete pain relief was 45% in surgery group and 20% in endoscopy group with a significant p-value. And VAS score was also significant in both groups with a p-value of 0.02. So pain was the main thing in early surgery group. It had better pain scores. Satisfaction wise, 71% of early surgery group versus 33% in endoscopy first group were satisfied with a p-value of 0.003, and re-interventions were 19 in early surgery group and 57 in endoscopy group, which was also significant. But the endocrine function, quality of life, mortality, complications, and safety of there were no difference between the two groups. For the subgroup analysis, The endoscopy group who then further converted to surgery had worse pain scores, visual analog score of 50 versus 29, and they had less complete relief of pain, although quality of life had no difference. Endoscopy clearance in long term had no significant benefit. Pain scores had no difference, and visual analog scores were better in early surgery. Overall pain trends in early surgery, there was stable and low pain scores, but in endoscopy first group, pain was worsening over time.
Okay, that's the point I mentioned about the subgroup analysis. What is interesting is that the outcomes in terms of pain was not different whether you had complete clearance or not. That is something which is surprising in this, because many people earlier used to say that the better clearance that you have of the ducts, better is the outcome as far as the pain is concerned. The other thing is, I want you to know that particularly in the surgery group, the onset of exocrine and endocrine deficiency is known or reported to be delayed. It's not completely, it's not completely negated. They do eventually end up with exocrine and endocrine deficiency, but it is delayed in those people who had a good drainage. That's the second point that is different. It's not a critique, but it's different. And the third point, which is relevant at this stage, which all of you must know, is that they have not mentioned it at all in this paper. There is a school of thought that leaving a stent, endoscopic stent, in a duct for a long time can lead to neoplastic or dysplastic changes in the ductal epithelium. It is one critique or one objection that is raised, not proven, but particularly something that we have to bear in mind if you leave stents in place for years on end. Those are the three relevant points that you need to know, not mentioned in this paper in any great detail as far as the endoscopic treatment is concerned. Okay, critique on the results. Do you have any objections, or do you see any problems with the results that these people have reported?
No objection, sir. All
Yeah.
the endpoints were very clearly defined.
Yeah.
And the follow-up was also very good. So, like the progression points and everything they have taken into consideration, not just looking for the at the last endpoint.
Right.
And subgroup analysis is also done. So
Yeah.
that's a good thing.
Right. All right. Go ahead, Sameer.
Sir, I had one issue.
Yeah.
In the early surgery group, there is still quite a number of patients who have undergone surgery again. I think it's some 24 or 17. I don't know the exact. I forgot the exact number.
Yeah. Yeah. But it's
So
not a
for
large
what
number.
reason?
It's not a large number.
Out of
Niranjan.
31. Out of 31.
Just look.
Who
I don't think it is
survived.
that many. It's not that many. Just
Sameer,
check on
Sameer,
that.
just show the data.
Yeah.
The number who have undergone surgery again, even in the endoscopy, and also they have compared.
Endoscopy was a large number.
Endoscopy was a large number. Even in the surgical group, it is
Just
still a
check
large
on that.
number.
I think its surgical group is quite small.
Very small as far as I remember. How many people had resurgery?
See, in that surgery group, it is around 28 patients in the early surgery group and 17 patients in the endoscopy first group. 45 patients underwent surgical treatment during the follow-up for chronic pancreatitis. Out of the 28 patients in the early surgery group and 17 patients in the endoscopy first group underwent surgery.
Repeat surgery?
In the subgroup. Yeah, repeat surgery.
No, I think I don't think
there's something amiss there, Niranjan. I don't think they had repeat
It is
surgery.
given in that subgroup
Re-interventions
1.
were done only in 11 patients, sir.
Yeah.
In
But
early
this,
surgery group, re-interventions
no,
only in 11 patients.
in that subgroup 1 column of the paper, surgery in the endoscopy first group. Out of that, they say of 61 patients who completed the survey at the end of follow-up, 45 patients underwent surgical treatment during the follow-up for chronic pancreatitis.
That is the endoscopy group, Niranjan. That's not
Sir,
the surgery group.
No, in that they say 28 patients in the early surgery group and 17 patients in the endoscopy first group.
No. I don't know. I think there is something amiss there. Yeah.
That is what I had an issue. What was that? Because that's quite a significantly high number.
No. I don't know. I don't have. Yeah. We'll have to check it up, Niranjan. Okay, let's go and check it up now because I can't check it right now and then look at the original paper. But as far as I know, the re-surgery
Reinterventions
group
were less,
were less in
significantly
the
less.
surgical group.
Yeah.
Definitely, yeah. I like to look it up. Yeah. Go on.
Sir, endoscopy group had a total of 45 interventions, sir.
Yeah.
And the surgery group, they also had interventions, sir, but then that was about like endoscopy clearance only, sir.
Yeah.
Resurgery is only 2. I think
No.
resurgery
Okay.
is only 2.
I'm looking at the original paper. Give me 2 minutes to see. I can see the tables and see.
It's not in the table, sir. It's in the matter where they mentioned subgroup 1.
Supplement 1 is there.
Okay.
Resurgery only 2 have undergone.
Resurgery only 2 patients, as far as I can remember.
Initial 18 months follow-up. Only one patient had a resurgery. New events after initial 18 months early surgery group 43. None of them had resurgery. Total follow-up between randomization. Yeah, only one patient had resurgery. And 4 out of the endoscopy first approach had resurgery. Yeah. Illa Niranjan, I don't think that a lot of people had surgery. Yeah. Okay, go ahead. Go ahead, Sameer. Go on.
So as mentioned earlier, intelligent analysis, predefined groups, and transparent method with subgroup analysis.
Yeah.
The adjustment were not done, sir. Adjustment in the sense of p-value across all the endpoints were not done. So only the pain scores p-values were pre-mentioned, sir. Other endpoints p-value was not mentioned, which has a potential of type 1 error.
Yeah.
And recall bias.
You mentioned about the recall bias earlier. Yeah. Okay.
And evolving techniques, because this was a paper from 2000, started from 2011 onwards, sir. So
what evolving techniques did you have in mind?
Sir, as sir had mentioned, US guided celiac plexus block, and then the lumen opposing stent, sir, intraductal lithotripsy, also the improved, the new ones, sir, endoscopic ultrasound therapies were mentioned.
They're not introduced. That's what you mean.
Yes, sir.
Yeah. All right. Okay, but I don't think that's a major issue because I don't think any of them has been shown to have a major impact on pain. Okay, as of now. Celiac plexus block, of course, yes, that's a time-tested method, but these newer endoscopic methods, not really all that advantageous. Yeah. Okay. But yes, it is one of the points that one should bear in mind. Yeah. Go ahead.
So early surgery is superior to endoscopy according to this for long-term follow-up and the initial escape trial. First, for long-term pain control, patient satisfaction, and fewer re-intervention in the early surgery group. Delayed surgery after failed endoscopy has worsened pain outcomes, and endoscopic ductal clearance surprisingly has no long-term benefit.
Correct.
These are a meta-analysis of long-term
Collateral
outcomes.
reading he has done. Yeah, go ahead.
3 RCTs with 267 patients were compared surgery versus endoscopic therapy. Same, they had in surgery group had achieved higher complete pain relief, but again there was no difference in quality of life scores in both the groups, and with no difference in new onset exocrine or endocrine differences. Similarly, another meta-analysis of 261 patients. In this study also, early surgery was associated with better long-term pain relief, fewer interventions, and improved physical health-related aspect of quality of life without any increase in complications or mortality. Same endocrine or exocrine pancreatic functions were generally similar between the two groups.
The other kind of vexing thing for me is that the significant number of patients, even despite it being a small group, significant of them patients were smoking and also continue to drink alcohol.
Yeah.
So which actually I think is I don't know whether it is a confounding factor, but it certainly maybe contributes to the.
Yeah. That's true. I mean, that's true of all populations, isn't it? They really don't give up. And
Yeah.
if you use that as an exclusion criterion, you won't have any study.
You won't have study.
That's a problem. Yeah. Okay.
Actually, there was a surgeon in UK a cardiac surgeon who refused to operate on patients who who did not give up
Smoked.
smoking, and so he was actually chastised by the court. So I
Yeah.
think you're right. It's difficult to.
All right. Okay, Likith, do you think this is relevant to our circumstances?
Hello?
Yeah. Do you think it's relevant to our circumstances, the study?
Yes, sir.
How do you say that?
Because
So the questions you have to ask whether it is relevant or not is to know, first of all, how many patients you see generally with chronic pancreatitis. Okay, you see a reasonable number. Okay, in 6 months you may not have seen much, but you will see, if you do 3 years, you will see a fair number. And is pain a major issue with them, or is exocrine or endocrine deficiency a major issue? Okay, the answer to that is pain is a major issue. And do they become dependent on analgesics, opioids or otherwise? The answer is yes. So for all these three conditions, for all these questions, because the answer is in the affirmative, you can say that this is relevant to our circumstances. Should we be following this recommendation or not? Do you think the data is robust enough for you to say, yes, I think we should offer them early surgery? Say something. Pregnant silence. I have never understood this phenomenon among our students. It's universal. Everybody doesn't say anything, doesn't commit anything. Okay. All right. Praveen, tell me.
Even in
Sir?
the groups that we go.
Yeah.
And even there is pregnant silence.
Correct. All right, Praveen, should we be following this recommendation?
According to this paper, no, sir.
Yeah. No? Should you not offer early surgery, or you should offer early surgery?
Based on the lateral study papers, based on those sample size, it's yes, sir. But solely based on this study, still I would think of it.
Why not? Why
Sir,
not?
the sample size is not enough,
Yeah.
and there is data errors in.
No data errors, man. No data errors. I think sample size is small, I agree, but it's a very thorough study and a very long-term follow-up. So even this study is, I think, good enough for you to say, but we have been, to be honest, we have been following the 3 surgeons in this group. I'm sure we all offer them early surgery in chronic pancreatitis. But the only thing I have is I don't offer them, and it's only 5 millimeters. I go by 10 millimeters. particularly for lateral pancreatic jejunectomy. And as Niranjan raised a very valid point, if there's a lot of parenchymal calcification, ductal decompression is less helpful. It won't help you much.
Correct.
Okay, you'll then have to resect that part of the pancreas, whether it's in the tail or head or whatever.
Yeah.
So that is, but if you look at the first paper in this, they have used the similar criteria for choosing the operation. Okay, but please understand that this is something that we have to follow. But the people we have to really impress with this data is who? Who should we? Physician, gastroenterologist. Okay, we should impress upon them that this is what is required.
Don't sit on them. Don't sit on them for long.
So give the recording of this journal club to
Vijay Kumar
and Purnachandra. Okay, very important. Okay, go on, Sameer.
Praveen, what you have to understand is that even if you look at the meta-analysis, the numbers are only 260.
Yeah.
So I don't think it's it's not a common problem, and I think the significant studies have come from Kerala. I think definitely Dr. Philip Thomas, when he was there, and Ramesh, I think they have published quite extensively about the surgery for chronic pancreatitis, because Kerala is endemic for chronic pancreatitis due to the cassava or whatever that
cassava,
tapioca.
Yeah.
So I think the frequency of the disease needing surgery, I think, is quite small. I don't think it's a very huge problem. So you can't say that the data is small study, so we can't take the data. I think the recommendations are very clear, but I think they have proved it beyond doubt that surgery is the mainstay of treatment in patients with pain in chronic pancreatitis.
All right, Sameer, go on.
Yes, sir. So the total patients who have completed the survey is 61, sir.
Yeah.
Surgeries were performed in 45 of those patients. Out of those 45 patients, 28 patients were in the early surgery group and 17 were in the endoscopy group. Out of those 17 patients, they had worse pain score, sir. So that was the whole thing of yes.
Yeah. Okay.
Sir, my one thing was that although pain was better, sir, why quality of life did not improve in these patients?
Yeah. It's a good question, but it's a much wider, if they use the SF-36 for quality of care, quality of life scores. It only shows that pain is not the only thing that matters for quality. Okay. Their attitudes, their general energy levels and things like that. And also don't forget the system. These are all, they really don't have a great incentive to work because the state supports them in England or in Netherlands or wherever. And so you find that they may not keep themselves very busy with work. And so in such kind of people, because they have no distractions, their overall quality of life may come down. So quality of life is a much wider set of kind of concept. But the important thing is that the pain got better, because that is the primary problem with all these people. And of course, also note what Ravi had mentioned earlier, quality of life for people who are on alcohol or who are chronic smokers can never be very good. That's for sure.
Sir, actually, I think at the risk of being politically incorrect, unfortunately, I think especially in the West, it is a disease of the lower socioeconomic strata. And whatever you said about them being on the social support and dole and things, holds good. So the incentive to work or incentive to get better is minimal.
Yeah.
Because they are dependent on the state for this. So I think I rarely saw patients from the middle class and upper middle class with chronic pancreatitis. It is possible it will be there, but it is skewed very heavily in the favor of the lower social economic strata.
Okay, Sameer, anything else?
No, sir.
That's it. Yeah. Okay, thank you very much. Closing remarks from Niranjan first and then Ravi, please. Yeah.
Sir, well presented and good discussion, sir.
Ravi?
I think Sameer is, getting better and better significantly. You can see he has put in a lot of effort looking at the first paper, collateral reading, and also looking at all I think the data points were all presented with clarity, and he has understood the paper to a large extent. So I think it's good and
Agree?
well
I
moderated
agree.
by you, sir.
Thank you. But yes, Sameer did a lot of good work. Yeah, I agree. All right. Thank you. I'll close the meeting now.
Thank you, sir. Good night.
Good night. Good night.